58 of you are here. More will be coming. Okay, today we'll be dealing with hematology practical, what has been covered in the practical hall, in the practical class. We finished the gross specimens. We finished the slides, microscopic slides, and today we'll be continuing with the hematology practical. There are charts of hematology which you should see and interpret. Like you should see, there will be a clinical history and there will be a laboratory report will be there, either peripheral blood smear or other supporting blood investigations, or there will be bone marrow, some investigations will be there. They will be given to you. Then questions will be asked to you like this, and you have to answer those questions. Okay. Let's start with the first hematology case. A 19-year-old female patient came to the OPD with severe pain in the right iliac fossa. So there is 19-year-old female, severe pain in the right iliac fossa. She was asked for a hematological examination as a part of pre-operative checkup. So it is sure that she is going for a operation. So it is in the pain is in the severe pain which is in the right iliac fossa. So the peripheral blood smear report, it was reported as follows. RBCs were normocytic, normochromic. In WBC, total count was increased 16,000 per cubic millimeter, whereas the normal total WBC count is 4,000 to 11,000 per cubic millimeter, and the differential count neutrophils is increased 90%. Lymphocytes relatively decreased, and rest are normal. Platelets adequate and parasite not found. So, what is your impression in the peripheral blood smear examination? Anyone?
Neutrophilia.
Okay, neutrophilia. One is neutrophilia. Okay. Next. Next. Sorry.
Acute appendicitis.
Acute appendicitis is, see, write your impression on the peripheral blood smear examination. This is not a gross or a microscopic section. This is not a gross specimen or a microscopic slide. So you have to write the impression on the peripheral blood smear examination. Here you have to see the total count is increased, which is 16,000, which is increased. So it is a leukocytosis. And in DC, differential count, neutrophils is increased. So there is leukocytosis with neutrophilia. Is that all right?
Yes, sir.
Okay, we can call it neutrophilic leukocytosis also. Might be in the class, yes. Neutrophilia, you can write in the bracket neutrophilic leukocytosis, or just write neutrophilic leukocytosis, that will be enough. Mention two other clinical causes where we get a similar blood picture. Can someone say?
Acute infections.
Oh, acute infections and sepsis. Okay. So it is
myocardial infarction.
Okay, myocardial infarction, acute myocardial infarction. Okay. So we'll talk about that. For your reference, I have kept a picture of neutrophilia here. You can see here there are many neutrophils. These are all neutrophils. This one is band. Okay, you can see many neutrophils here. Along with this is the band. This is also a band, and this is also a band. So here you can see mostly neutrophils, and definitely there is increase in total count. These are the RBCs. This is the WBCs, where there is the mostly neutrophils are there, and these small fragmented like things are these small tiny things are the platelets. So these are the things you see in the peripheral blood smear. You see the RBCs, which look like normocytic normochromic. There is total count is increased with neutrophilia in case of WBC, and platelets, they look normal in count. And there are no any hemoparasites seen in this field. So it is neutrophilic leukocytosis. Can anyone tell why these are neutrophils?
It has multi-lobe nuclei connected with thin chromatin threads.
Very good, very good. There can be 3 to 5. Okay, 3 to 5 lobes can be there, which are connected with thin chromatin threads, and there will be presence of azurophoric granules in the cytoplasm. Okay, so these are neutrophils. Now this is the band. This is the band from promyelocyte to myelocyte, metamyelocyte, myelocyte, metamyelocyte, and then band. Then there will be cleaving, and then there will be neutrophils. Okay, now let's talk about the cause of neutrophilia. This causes of neutrophilia and cause of neutropenia. This is very, very important, and this will be asked during your table viva or main viva, or during the hematology section of your even SAQ, PBQ, or MCQs. They will be asked. So this is very, very important to know the causes of neutrophilia and causes of neutropenia. Okay, so in neutrophilia can be seen whenever there is acute infection like pneumonia, acute appendicitis, acute cholecystitis. The earlier case, this was a case of acute appendicitis, or peritonitis, abscess, intoxication like in uremia, diabetic ketoacidosis, eclampsia, inflammation from tissue damage. So these are all the causes of neutrophilia. Even the neoplastic conditions like polycythemia vera, CML, myelofibrosis, there will be neutrophilia. And neutropenia means there will be decrease in neutrophils. They will be present in infections. Some of the infections like typhoid, brucellosis, measles, and miliary TB. And drug and physical agents like anti-metabolite drug, irradiation, nitrogen, and hematological and other diseases like aplastic anemia, pernicious anemia, and SLE. So this you should know. Second case. A 35-year-old male presented with a dry, persistent cough and breathlessness for the last 1 year, and X-ray chest showed woolly opacities. There is dry, persistent cough and breathlessness. Breathlessness means difficulty in breathing for the last 1 year, and X-ray is done and showed woolly opacities like wool. Opacities, there will be opacities like wool. And his routine blood examination showed RBCs. This is the peripheral smear, okay, and normocytic normochromic RBCs with moderately elevated total count, where 11,000 is the normal count upper limit of the total count, but here it is 11,500 per cubic millimeter. And in differential count, rest are almost normal, where eosinophil is increased. So there is eosinophilia. Increase in eosinophils is known as eosinophilia. Platelets adequate, and in parasite, a microfilaria was seen in the peripheral blood smear. So comment on the differential count. Comment on the differential count, anyone? Saksham Thapa. Saksham Thapa. Are you listening me?
Yes, sir. Yes,
Okay.
sir.
Okay. Saksham Podel. Okay.
Yes, sir.
I mixed Sankalp Thapa and Saksham Podel. Okay, Saksham
Yes,
Podel.
sir.
Can you tell or comment on the differential count which we have discussed?
Eosinophilia,
Okay, why eosinophilia?
because there is the increase in the eosinophil count.
What is the normal level of eosinophil, or in differential count, what is the normal percentage of eosinophils you see in the normal person?
2 to 6%.
Very good, very good. So what are the causes of eosinophils? Mention two other clinical conditions where you will find similar type of differential count. One is microfilaria, okay, or parasites.
Yes,
Other
sir.
two conditions?
Allergic conditions,
Very good. The rest one?
parasitic infections.
Okay, that is microfilaria, which we have already discussed. Yes?
Yes, sir.
Okay, then I will ask. Okay, thank you.
Thank you,
This
sir.
one, Sankalp Thapa. Sankalp Thapa.
Yes, sir.
Okay, now you have to tell why this is a eosinophil.
Sir, it has a bilobe nuclei
Very good.
and reddish granules can be seen in the cytoplasm.
Eosinophilic granules. Okay,
Yes,
we don't say reddish granules, we say eosinophilic granules. Okay, whatever you are telling is very good. There will be granules which will be reddish, or layman call is reddish, we call it eosinophilic, right?
sir.
And there will be bilobe nucleus more often, but we can see three lobes. Like here you can see the three lobes. There can be 2 to 3 lobes of the eosinophils, but more often we see 2 lobes, and they are joined by a thin chromatin thread, right?
Yes, sir.
Okay. There can be spectacle appearance also. See this? Yes?
Yes, sir.
Okay. So, what is the size of eosinophil?
2 to 4 micrometer diameter.
What is the size of a neutrophil?
And 5 micrometer. 5 to 7 micrometer.
Okay. Okay, you have to check that. Okay.
Okay, sir. Okay, sir.
Okay. Now let's talk about causes of eosinophilia, like Saksham and Thapa, Mr. Thapa told. Allergic disorder, parasitic infestation, any parasitic infestation like roundworm, hookworm, tapeworm, echinococcus, and allergic disorders like bronchial asthma, urticaria, hay fever, drug hypersensitivity. So these will all cause eosinophilia, and other skin disorders like pemphigus, dermatitis herpetiformis, erythema multiforme, and pulmonary disorders like tropical eosinophilia, Loeffler syndrome, and Hodgkin's disease in the hematopoietic disorders, Hodgkin's lymphoma, chronic eosinophilic leukemia, polycythemia vera, pernicious anemia, and miscellaneous disorders like connective tissue disorder and irradiation. This will cause eosinophilia. You should know at least allergic disorders, parasitic infestation, skin disorders, hematopoietic disorders. You should know Hodgkin's disease and connective tissue disorders. This you should know. Is that fine? Okay, Suraj Acharya. Suraj Acharya.
Yes, sir.
Okay, can you please revise the causes of eosinophilia which we have just discussed?
So it can be due to allergic conditions.
Very good. Like
in
one is
bronchial asthma.
Very good. Other?
And it can be due to parasitic infections like hookworm, tapeworm.
Hookworm, tapeworm, roundworm, all everything. Okay, and then
Skin manifestations like urticaria, dermatitis.
Okay, pemphigus, urticaria, and in allergic conditions.
Asthma.
Okay, asthma, hypersensitivity disorder, hay fever, and other conditions. One important I had told, connective tissue disorders.
Yes.
Okay, and you can see here what are the causes of eosinophilia. You should know this: steroid administration. Okay, and don't forget this Hodgkin's lymphoma. Okay. Okay, thank you. Now let's go with the third one. A 35-year-old pregnant lady came to the gynecological OPD for antenatal checkup before the birth of the baby is antenatal checkup. She was complaining of weakness and loss of appetite, and on clinical examination, patient showed severe pallor. You know what pallor means? In ICM, you must have been taught pallor. What does pallor signify?
Pale skin color.
Okay, what is that due to?
Decreased blood circulation or decreased hemoglobin count.
That is due to anemia. Okay. Simple thing. That is due to anemia. Someone is speaking, but I am not able to. You have a broken voice. Someone is speaking. Okay, that is due to anemia. So here you can see the routine blood examination is done. So always a case of anemia, you should start investigating with routine hematological investigations like hemoglobin. Hemoglobin is 5 gram per deciliter. It is increased or decreased or normal?
Decreased.
Okay, it is markedly decreased. So in this 35 years lady, 35 years female, what is the normal reference range of hemoglobin?
14 to 16.
Okay, very good. Then RBCs, the size is less than 6 micrometer. In WBCs, total count is almost normal, differential count normal. Platelet adequate, parasites, no malarial parasites seen. So the problem is with hemoglobin and RBC. PCV here you see decreased, MCV is decreased, MCV is 60 femtoliter. So what does this signify? What does this MCV signify?
Size, volume of RBC.
Okay, that is called
mean corpuscular volume.
Mean corpuscular volume. Okay. But what is that RBC called morphologically? Okay, microcytic. Okay, microcytic. So this is a anemia and MCV is decreased. Normal is 80 to 100 femtoliter. If it is less than 80 femtoliter, then that is microcytic. If it is 80 to 100, then it is normocytic. If it is more than 100 femtoliter, then it is macrocytic. So this comes under a microcytic RBC. And there is anemia. So this is a microcytic anemia. And MCHC and MCH, hemoglobinization all is reduced. And here you can see the iron profile where the serum iron, serum ferritin is reduced and serum iron binding, total iron binding capacity is increased. And bone marrow shows that the iron store is reduced. So what is the diagnosis?
Iron deficiency.
Okay, iron.
Microcytic.
Okay, microcytic hypochromic anemia according to this. Okay, but here all the iron profile is given with serum iron and serum ferritin which are reduced, and there is increase in serum total iron binding capacity. So definitely this is a iron deficiency anemia. Okay, if this is not given, then you can say it is a microcytic hypochromic anemia. But if this is given, then this is definitely a iron deficiency anemia, because we have seen in the bone marrow also iron store is reduced, and in serum also total serum iron is decreased, serum ferritin is decreased, and TIBC is increased. So this is definitely a iron deficiency anemia. So name one parasitic infestation which may lead to similar picture.
Hookworm.
Okay, very good. Hookworm. So here, for your reference, I have kept the peripheral blood smear of a microcytic hypochromic anemia, which is iron deficiency anemia. Here you can see there is anisopoikilocytosis with variable size and shape of the RBCs, and here you can see which is the pallor is increased. Normally, the pallor will be present in the inner 1/3 or the central 1/3 of the diameter of the RBC, but it has increased. This is due to the decreased hemoglobinization due to deficiency of the iron. Here you can see pencil cells, leptocytes you can see, and here compare the size of the RBCs with the nucleus of the normal small lymphocyte, that is less than that of the size of the lymphocyte nucleus. So this is microcyte. So this is microcytic hypochromic anemia, which is mostly due to iron deficiency anemia, and these all RBC indices have been given along with serum iron profile. So this is a iron deficiency anemia. So let's go to fourth. So a 3-year-old male child admitted in our hospital with severe anemia, massive splenomegaly, and history of regular blood transfusion. The patient has a mongoloid face. The blood examination showed hemoglobin is again 5 gram per deciliter. RBCs are microcytic hypochromic. There is anemia. Marked anisopoikilocytosis is there, and there are many target cells along with many teardrop cells. WBC is normal, otherwise platelet is also adequate. PCB and MCV decreased. Other tests which are done, reticulocyte is increased and fetal hemoglobin is increased. So here a 3-year-old male child, severe anemia is there, massive splenomegaly is there, and there is history of regular blood transfusion. And in blood exam, in mongoloid face is there. So you have to take all these clinical scenario. So you have to take all these clinical vignettes in your mind. And hemoglobin C, 5 gram is, per deciliter. So there is anemia, severe anemia is there. Okay, and along with microcytic hypochromic picture with marked anisopoikilocytosis, many target cells and many teardrop cells with decreased PCV and MCV. Increased reticulocyte, increased fetal hemoglobin. So what is the diagnosis?
Thalassemia.
Okay, very good. Thalassemia. So why do you say this is a thalassemia?
Fetal hemoglobin is increased.
Very good. Very good. Fetal
There is
hemoglobin.
blood transfusion
Okay,
needed in the thalassemia.
there is a history of regular blood transfusion. Okay, one is this.
And target cells, teardrop,
Okay,
microcytic.
target cells. More than teardrop cells, I would say target cells. Okay, if it is a microcytic hypochromic anemia with many target cells and a clinical indication, clinical features indicating some hemoglobinopathy, then it is more likely a thalassemia with this fetal hemoglobin increased. Okay, how will you confirm this disease? How will you confirm if it is a thalassemia? One, there is increased electrophoresis. Okay, electrophoresis you will do. So there will be one is increased fetal hemoglobin will be there. So there are many according to the classification, there are many types of thalassemia, right? Broadly, they are classified into alpha and beta thalassemia, and there are subcategories of those thalassemia, those types. So here, for your reference, see the peripheral blood smear. Here you can see these are the target cells. These all are the target cells. So this is of a thalassemia. So here the next question is, how do you classify the disease? Or it is asking about classify the thalassemia, types of thalassemia. So what are the types of thalassemia? Classification of thalassemia, anyone? Prasiddhi Acharya.
Yes, sir.
Okay, can you please tell what are the types of thalassemia?
Sir, first it can be classified as alpha and beta thalassemia.
Very good.
Then alpha thalassemia can be further classified as silent care on the basis of how many alpha are missing. Then it
Alpha what? Alpha what?
chain.
Okay, of the. Okay.
Of the hemoglobin, it can be classified as silent carrier alpha in which there is only one alpha chain is missing. Then alpha thalassemia trait where two alpha chains are missing. Then
More than 10, this is about the gene. Okay,
yes, sir.
This is about the gene because there is there are this thalassemia is related to the heme or the globin.
Sir, heme.
It is related to heme.
No, sir, globin. Sorry.
Okay. So the gene which encodes this globin can be present in the. What are the genes that encode globin?
So alpha and beta.
Okay, there will be 4 genes, 2 genes in the alpha and 1 gene for the beta. Okay.
Yes, sir.
And that means if it is a 2 genes for the alpha, there will be 4 alleles for the alpha.
Yes, sir.
Are you understanding? If
Yes.
it is one gene for the beta globin chain, then there will be 2 alleles. For every gene in our body, there will be 2 alleles. One will be paternal allele and one will be maternal allele. Okay.
Yes, sir.
So here, if there is, there are two genes which will be encoding the alpha globin chain. That means there will be 4 alleles. Out of that, if one goes and 3 remain, that is the silent carrier. Silent carrier means that person is only the carrier, and it is not the clinical features are not that overtly seen in that patient. So it is a silent carrier. And then there will be, yes, continue.
Sir, then if the 2 alleles are missing,
Okay.
then it's alpha thalassemia trait.
Okay.
And if 3 are missing, then it's HBS disease. Then if
Very,
it's all the alleles are missing, then it's hydrops fetalis.
very good. Very good. What about beta thalassemia?
Sir, it can be classified as beta thalassemia major, beta thalassemia intermedia, and beta thalassemia minor.
Okay, this much is very good. If you know and if you can tell this much, this is very, very good. Okay, we'll move to the 5th card, hematological card. A 5-year-old female child present with severe pallor. Now you know what pallor means. Yes, it is related with anemia. Whenever there is anemia, there is pallor clinically. There will be malaise and there is weakness of the lower limbs and recurrent diarrhea is there. On clinical examination, tongue showed features of glossitis. Blood examination showed hemoglobin is 5 gram. RBC, size of the RBC is more than 8 micrometer. WBC, total count is 3500 per cubic millimeter. And in differential count, few hyposegmented neutrophils are seen. Otherwise, the differential count is normal. And platelets is reduced. And MCV is increased. Here you can see MCV is increased. And bone marrow examination shows marked erythroid hyperplasia and with presence of numerous megaloblasts. And myeloid is to erythroid ratio is altered, which is in favor of erythroid. Because there is erythroid hyperplasia, this ME ratio is shifting towards the erythroid. Okay, and iron store is normal. So what is your diagnosis? Keep everything in mind, which we have.
Megaloblastic,
Sorry.
megaloblastic anemia. Megaloblastic anemia.
Okay, it is megaloblastic anemia. Very good. But what are the features? What are the features in favor of megaloblastic anemia? Yes, Rahul Singh. Why did you say this is a megaloblastic anemia?
Because megaloblasts are seen in the bone marrow as well as erythroid hyperplasia is seen.
Very good. One is that there is a megaloblast. There is presence of numerous megaloblasts in the bone marrow. That is the one and only important thing which we should know. If there is presence of megaloblast, that's why it is known as megaloblastic anemia. But these all are the supporting features. Here you can see there is pancytopenia. You know what pancytopenia is, right? You people know what pancytopenia is? Anyone can speak?
All the lineage of cells are decreased.
Okay, all the cell lineages are decreased. Like hemoglobin is also decreased. See, it is 5 gram per deciliter. And then hemoglobin and RBC is decreased. WBC, it is decreased 35. Normally is from 4,000 to 11,000 per cubic millimeter, but it is decreased. And platelets are also reduced. Means all the 3 lineages of the blood, they are decreased. So that this is a pancytopenia. So why there will be pancytopenia in case of megaloblastic anemia?
So due to the deficiency of vitamin B12, there is no formation of thiamine, so that there is no cell division occurring. So all the lineage of the cells are decreased in number.
Okay, partly correct. Any other? Okay, not only the erythroid series, but also the myeloid series of the cells will also be affected. Yes, very good. One is that. But there is other major reason for pancytopenia or sometimes bicytopenia can be there if any two of the three lineages are involved. Okay, what might be the other cause? Anyone? Okay, before that, from here you should extract what are the features of megaloblastic anemia. One, he has told there is presence of numerous megaloblast. So because of this presence of megaloblast, it is known as megaloblastic anemia. Here you can see this is a picture from a bone marrow. These are the erythroid cells. These are all the erythroid cells. If you can see, here you can see sieve-like chromatin in this nuclei. You can see sieve-like chromatin means there will be some porous-like chromatin. Okay, so these are known as megaloblasts. And here in the peripheral blood, this is the peripheral blood smear picture, and this is the bone marrow picture. Here in the peripheral blood smear, you can see there are large RBCs, enlarged RBCs, which are macrocytes. These are the macrocytes. Whereas if you can see, these are the normocytes. These are of the normal size. Whereas these are all macrocytes with presence of hypersegmented neutrophils. If you can count, see this 1, 2, 3, 4, 5, 6, 7, 8. 8 segments are there in the neutrophils. So is this normal?
No, sir.
Okay. Okay. Macrocytic anemia with hypersegmented neutrophils with megaloblast in the bone marrow. This is definitive of megaloblastic anemia. And due to this megaloblastic maturation, there will be ineffective erythropoiesis. That means these erythroblasts will not mature to RBCs, and they will die within the bone marrow itself. So the bone marrow will be packed with these type of megaloblast and the dead erythroblast. So that will occupy the space so that there will be bicytopenia or pancytopenia. Okay. Now the sixth one. Can anyone go through this? One of you please go through this. Okay. Sisir Ariel.
Yes, sir.
Okay, please go through this. Read this.
I'm not. A 4-year-old male child presented with anemia, fever, nose bleeding, and hepatosplenomegaly for duration of 1 month.
Okay.
Routine hematological investigation showed hemoglobin 0.5 gram per deciliter, RBC normocytic normochromic, WBC total count is increased,
Okay.
blasts 94%,
Okay.
neutrophils 0.5%,
Okay.
eosinophils neutrophils 5%, eosinophils 1%.
1%. Okay.
There are no or rods seen in the blast cells.
Okay.
Platelets are reduced.
Okay. What is the diagnosis then, Sisir?
ALL, sir.
ALL. Can you please tell the full form of ALL?
Acute lymphocytic leukemia.
Okay. So whenever you talk, please do not talk do not say the short form. You should always tell the full form of all the abbreviations.
Okay, sir.
Okay. Okay. Why do you tell that it is a ALL or acute lymphoblastic leukemia?
So because it is presented in a 4-year-old child.
Okay.
There are no or rods are seen. And
What is the
WBC count?
criteria? What is the criteria to tell that it is a acute leukemia according to WHO?
Blast cells are increased.
So what should be the percentage of the blasts?
Only 5 to 10%.
Normally 5 to 10%. Normally there should be 1 to 2% in the that is in the bone marrow. Here in the differential count in the peripheral smear also you are getting 94%. So according to WHO, anyone else who can tell?
More than 20%.
Very good.
20%.
It is more than 20%. If the blast percentage is more than 20%, irrespective of the total count. Okay, here the total count is increased. Okay, here the total count is increased. It is 1,20,000 or 120,000 per cubic millimeter, along with 94% blast. So definitely the blast is 94%. So it is an acute leukemia. Now, after acute leukemia, we should classify that whether that is a AML or a ALL, means acute myeloblastic leukemia or a acute lymphoblastic leukemia. And here the morphology of the blast is given. They have scanned cytoplasm with nuclei showing coarse chromatin and single nucleolus, and no R rods is seen. So this indicates towards the lymphoblast. If they had moderate amount of cytoplasm, okay, and multiple punctate nucleoli or prominent nucleoli with granules in the cytoplasm and R rods, then it would be a myeloblast. So with all these things, you have to say this is a acute lymphoblastic leukemia, and you have to see the age also. So what is the diagnosis? We have discussed that. What other investigations can you do to confirm the diagnosis? Anyone? Okay, Tanuja Khatri.
Yes, sir.
So what other investigation can you do to confirm the diagnosis?
So bone marrow biopsy.
Okay, bone marrow examination you will do. In bone marrow examination, you will have both aspiration and biopsy. Okay. What else, if you know? Just know the name. Yes. I know that this has been covered. You do cytochemical stains like PAS, periodic acid SIF stain, or which stain? MPO, and PAS stain we do. And along with the bone marrow aspiration and biopsy, we do cytochemical stains. And the other one confirmatory is flow cytometry. Just know the name, flow cytometry. So what other investigations? Because here not only single investigation, but what other investigations can you do has been asked. So you have to just write the name. Bone marrow examination can be done, flow cytometry can be done. Is that okay?
Yes, sir.
Okay. So here you can see there is increase in total count. Here you can see definitely there is increase in total count with many blasts. These blasts are, see, they are large with scanned cytoplasm and coarse chromatin of the nuclei, and majority have a single nuclei, and they do not have R rods. So this is a acute lymphoblastic leukemia. So seventh one. Okay, one of you please read this, go through this fast. We'll have to finish hematology today. Okay, Sabal Pandey.
Yes, sir.
Okay, can you please go through this?
Yes, sir. A 16-year-old male presented with fever and hepatosplenomegaly and pallor for last 3 months. On physical examination, the patient showed sternal tenderness and epistaxis.
Okay.
Routine blood examination showed hemoglobin 0.5 gram per dl.
Not 0.5, it is 5, 0.5.
5 gram per dl.
Okay,
RBC,
this hemoglobin is normal?
no sir, it is reduced.
Okay.
RBC normochromic and normocytic, it is normal.
Okay.
WBC total count is 1,20,000 cells per deciliter. It is increased. The normal should be about 6,000 to 11,000 cells per deciliter.
Okay.
Differential count, blast percentage is 80%, and blast are showing O dots. This is also abnormal, and the blast, they are more than 20%, so it signifies it is acute, and blast so O dots, which signifies it is myeloid, of myeloid lineage, so it is acute myeloid leukemia.
Very good, very good.
Neutrophils 15%. It is decreased. Lymphocytes 5%, and platelets severely reduced.
Okay. Very nice, Sabal. Very good. So he has talked about all the things. So blast, total count, hemoglobin, everything he has talked about. Okay. Now, what are the cytochemical stains that we can do to confirm the diagnosis?
Myeloperoxidase and PAS, periodic acid Sif stain.
So you told that this is a AML, right?
Yes, sir.
So if it is a AML with OR rods, then which of the cytochemical stain will be positive in this case?
So myeloperoxidase will be positive and PAS will be negative.
Very good. Very good. Thank you. So here you can see this is a acute myeloblastic leukemia M2. So FAB classification, if you see, there is the classification is M0 to M7. There are 8 subtypes in the FAB. So according to the FAB, there is M0, M1, M2. So you should go through this. All right. But here what I wanted to show is this OR rod. See, there are 2 OR rods. So this signifies, and there is moderate amount of cytoplasm, more than that in the lymphoblast. So this is a myeloblast. Whenever there is presence of a OR rod, then that is for sure a myeloblast. So 8th one. Okay, Aditi Podel.
Yes, sir.
Can you go through this?
A 45-year-old male presented with weight loss, malaise, sensation in the abdomen.
Okay.
On physical examination, he had hepatosplenomegaly. Routine blood.
Sorry, Aditi, I am not getting your voice. It is breaking.
A routine blood examination shows hemoglobin 8.
Again, it is breaking. Your voice is breaking. I think we should. You have any problem with the internet? Okay, thank you, Aditi. We'll take Rasna Pradhan. Rasna Pradhan, are you there? Rasna? Rasna Pradhan. Yes. Okay, then for today, we'll stop here. Two more cases of hematology are remaining. We'll cover this in the next class, next Friday. Okay, thank you very much. If you have any questions regarding this, we'll discuss in the next class. From the previous class, do you have any questions? Okay, if you don't have any questions, we'll hang up. Thank you. Yes, sir. 78. 77, including me. 70. Okay, thank you.
Thank you, sir.